Bikini incision is something that's grown in popularity. And these are my disclosures that really have nothing relevant to this talk. Special thanks again to Tyler. So anatomy of the skin. This is really what we're talking about when we deal with these different angles and longitudinal versus transverse incisions. And we know from Juan's talk just a few minutes ago that when we place incisions across the collagen at different levels, that we get different responses as far as tissue healing and collagen fiber repair. So the skin is anisotropic, and what that means is that the mechanical behavior is not the same in every direction. And so Langer's lines, which has been previously, let me just move through this slide for you here. So this is a good way to remember that. So the rubber band or the TheraBand on your right, which has memory and can get back to its original shape, as opposed to the collagen fibers on the Sharpay. So the anatomy of the skin initially described with regards to the Langer's lines, as you can see across the hip joint, anteriorly in particular, you can see how the bikini incision kind of had its origination here. So on the upper part of the anterior surface of the thigh, constantly observed an oblique direction of the clefts running downward from the lateral to medial, and these always remain the same in different positions of the hip. So there's also a condition from the stria distensae, which is this dermatologic condition, and you'll notice that what happens is that the optimal skin incisions are perpendicular to these collagen, essentially severe stretch marks. So this is the basis for the bikini incision. So the skin incision is much more transverse than the typical standard vertical DA incision. The location, however, of this is quite important, and we'll get into that, and that's probably the most important part of this talk, which won't duplicate some of Juan's work. But the deep dissection is the same. So there's nothing from tensor fascia to the hip that is different from the bikini incision versus a conventional incision. So, but I do think you need to know the pitfalls. So the incision is more distal than you would initially think, and it's 8 to 10 centimeters distal to the ASIS. So I follow the flexion crease if you can on this incision. So sometimes the flexion crease of the hip will correlate with this level, and I have no problem putting the incision directly in the flexion crease. I don't think that's an issue. I think it's much safer to do that than to cross the flexion crease. So the instrument selection, I would say it's really personalized. The self-retaining retractors for the skin are important. I try to limit my cautery use in the sub-Q area, but effectively you're taking a horizontal incision and turning it into a vertical approach deep. So you need to be able to mobilize the dermis enough to be able to get the length of incision you need to do your procedure safely. So radiolucent blades for the Charnley is something that we use routinely so that we can image through it for the cup. And then offset broche handles can be helpful to avoid tension on the skin. So the offset broche handles help avoid this tension at the superior aspect of the incision. I would say placing your incision in the right location is actually more important probably than just having an offset broche handle. So they help work around corners, and I think most of the surgeons who are well-versed at DA realize that sometimes that's what you're doing. You're working around corners, and we've instrumented better implants and better instruments, or created better instruments to make that happen. So I'm not sure we've unilaterally changed what hip replacement looks like, but I think we've changed the way in which we get there. So the downside to the offset broche handles is it dissipates the impaction force. And so sometimes you need to be either striking these harder and you may not get the same outcome or the same advancement of the broche. So the bikini incision, for me, the pros and the cons. The pros are the obvious ones, which is cosmesis. And another pro is that the deep dissection is not new. So it's not an entirely different approach for the surgeon. So you just need to learn the dissection from the skin to the level of the fascia and make sure you've mobilized this well. The cons are this: lateral circumflex artery control. That's one of the issues. because when you do your vertical incision, usually in the inferior portion of your incision, you can easily identify these vessels crossing anteriorly, and I think Christoph talks about preservation of them, but they're pretty easy to see, find, ligate, or cauterize. When you do the bikini incision and if you run your dissection then distal, frequently you don't have great access to them, so it can be harder to control them. The distal fascial closure can be challenging, and for many surgeons, they have no idea about this because they're not even in the room. So whoever's closing your incision is going to struggle at the bottom of the fascial incision closure if you try to do a small bikini, particularly if you place the incision too proximal, which is the most common error. So, and the other con is that there's no extension of the bikini into a more extensile exposure if you had a periprosthetic fracture or for a subsequent surgery. So let's see some data. So this is some of the data that Juan just presented. So this is Michael Lloyd's paper showing basically a better cosmetic result with no difference in other outcomes, but again had a very select patient group of low BMI females. This is Brent Lanting, one of our former fellows up at Western Ontario, did a cadaveric study, and then they had an anatomist come through and do the dissection and look at muscle damage and LFCN injury and found no difference. And then finally, this is also from Michael Lloyd again in 2018, retrospective study looking at almost 1,000 patients between longitudinal and bikini incision. No difference again between their hip scores, stem placement, and revision rate. Let's see. There we go. And then finally, the last paper that was just discussed by Juan looked at the scar assessment scale complications, single surgeon series with the predominance of conventional versus bikini, and the outcomes from those really showed no difference between any parameter that was measured. So DA could be performed through an alternate horizontal skin incision, which was the conclusion of this author, with similar results. And they also recommended that those performing this technique would benefit from training under the guidance of an experienced surgeon, because this was the one issue that came up. Bikini, delayed wound healing, 2.3%. Obese patients, 0. Conventional was 6.1, and that was significant. And so I think if you do the procedure well, you can have excellent outcomes, but certainly you want to know where to place it. So my preference for total hip arthroplasty incision, this is truly just my opinion on this. I measure the distance from the ASIS to the hip flexion crease. If that number is less than 6 centimeters, or if it's a very muscular male, or if I think I'm going to need distal extension or proximal extension, I would use a standard vertical incision. So kind of 6 centimeters is my mark. Because if it's more than 6 centimeters and the flexion crease is low, I don't want to cross the crease, and I'm going to probably have some impingement and damage the dermis proximally when I'm preparing my femur if I move the incision more distal to that 6 centimeters. So in that case, the bikini incision puts me right in line with the flexion crease. I put the incision in the crease or lower than the crease, more distal than the crease. It also becomes more, for me, more applicable in the obese patient. And Juan showed that data with better healing rates in the obese patient. And women, I think, also have a predominant, they would prefer to have the scar that's more thin. They actually spend a little bit more time talking about that or asking about that versus some of the male patients. So conclusions for me, bikini incision is viable for DA. It's probably ironically best in the obese patient. So incision placement is really the key. Retractors and instrument handles can simplify the technique. Surgical observation is recommended prior to performing, and you just must know the secondary incision options for extension. There's nothing worse than being in a surgery, having a complication or something happen unexpected and not having the ability or the knowledge to be able to address it in the same surgery.